about a minute. Today's webinar is presented to you by the Data for Nutrition Community of Practice, and also is prepared by a nutrition collaborative that has been working on the revisions for the Demographic and Health Survey. We're going to talk about how might the Demographic and Health Survey collect more and better nutrition data. My name is Cecilia Gonzalez. I'm the Data for Nutrition Community of Practice facilitator, and I'm going to give some quick instructions for this webinar. So all microphones are muted during the presentations. If you have any comments, please use the chat box at the bottom of your screen to chat with other participants. You can contact Charmin Sultana if you have any technical issues. We will be trying to answer as many questions as possible during the Q&A session. If you have questions, please include the name of the speaker and to whom you're addressing your question. We will be sharing a recording of today's webinar, and it will be immediately available on the Data for Nutrition YouTube channel. If you're experiencing any technical difficulty, exit the webinar and open a new browser. Re-enter using the webinar link and run the audio setup wizard. So the Q&A is in the bottom menu, and that's where you can enter your question, and please try to be specific to if you're addressing that to any of the speaker or panelists. If you're having any trouble, again, please contact Charmin Sultana by going to the chat box and choosing her name there. We will try our best to respond during the webinar. And without further ado, I'm going to pass it on to today's moderator. Rebecca Heikam is Associate Research Professor at the Johns Hopkins Bloomberg School of Public Health. Again, today's webinar is hosted by the Data for Nutrition Community of Practice, also known as DFN, which provides members with opportunities to share knowledge, experience, and questions relevant to strengthening the nutrition data value chain at all levels for the purpose of achieving better nutritional outcomes in low and middle income countries. Welcome, everyone.
Thank you, Cecilia. I appreciate it. You can go to the next slide. So I want to say to welcome everyone to our webinar today, and I'm sure many of you are drawn to this topic of the demographic and health surveys, because for many of us, demographic and health surveys are an incredibly important source of nutrition data. And as you may or may not know, every 5 years, the DHS program reviews and updates the core questionnaire that is used across more than 90 countries. And back in the last round of the DHS round 8, in 2018, the nutrition community actually had a big win. We submitted and advocated for 11 different recommendations about adding or changing nutrition-related content to the DHS, and we had an unprecedented more than 30 new nutrition questions added to the core questionnaire. We had a big win last round, and we've been told there might be some little bit less potential to change this round. But we still think it's really important that the nutrition community come together and share its recommendations during this opportunity so that we can really improve what it is that we're collecting. Now, the DHS has a very kind of set submission format, and there is an online portal, which we'll tell you more about later. And in this round, the DHS is actually putting a really strong emphasis on country-level demand for changes. So for those of you who are working in national institutions, it's really a round where the DHS has wanted to hear from you about what is it that you want. And at the end of this webinar, we're going to come back and talk about some of the ways that you can advocate. Now, the last few weeks have been very challenging for many of us, and I do want to acknowledge that officially right now the DHS program is on pause, and according to their website due to ongoing review. But the portal for the DHS 9 submission remains open. And so we thought it was really important that we move ahead, not only because these changes would matter when the DHS is resolved, but also because the information and these ideas can be useful to those who are designing national nutrition surveys or trying to design other surveys related to nutrition. So we really felt like it was important to move ahead. Next slide. So today you're going to hear about some recommendations that are being put forth to the DHS by different groups. We're going to have 3 speakers who are going to present recommendations. Nduzi Mbuya from GAIN will be presenting recommendations developed by a consortium of nutrition stakeholders. Christine Stewart from UC Davis will be presenting a recommendation coming from the SQLNS community. And Joyce Akpatka will be presenting some recommendations around diet and NCDs that are coming from Nigeria, a group of stakeholders in Nigeria, including GAIN. Next slide. After that, we're going to have a panel where we get some perspective from people working in national institutes of public health about how these recommendations could be used. And I'm going to actually come back and introduce these panelists right before the panel. So I just want to remind everyone, please go ahead and any questions or comments you have for any speaker, please go ahead and put them in the Q&A and we will navigate those and get to as many of them as possible when we get to the panelist and Q&A section. So now I'm going to hand over to Mdu. Welcome.
Thank you, Rebecca, and thank you, Cecilia, for organizing. And thank you to all the participants for attending this webinar and for your engagement in the chat so far. So today I'll present key recommendations for enhancing nutrition measurement in DHS Round 9. And in the background of my title screen, what we see is a global map with countries where the DHS data have been collected, with the bolder green countries where there's been more DHS surveys over the years. This is just to illustrate the global reach and the global importance of these recommendations and the opportunity that the DHS presents. Next slide, please. So while I drew the short end of the stick and I'm presenting on behalf of a consortium of global nutrition experts that consulted widely on these recommendations and sought alignment with current WHO guidance and SDG targets. So the Global Nutrition Measurement Consortium started meeting in August of 2024 and invited participation from groups and organizations that may have been interested. So we tried to cast the net widely. We worked in 4 subgroups to prioritize a set of recommendations and sought country and stakeholder review and endorsement, and thereafter solicited inputs from the WHO UNICEF Teams group, LENS, and WAHO. And we submitted recommendations having addressed the points of input. So we're now jointly promoting these recommendations through various fora, and this webinar is part of the process. Next slide, please. So we'll cover in this short presentation the 5 areas of recommendation that were addressed. First, household food fortification programs, food security measurement, anemia and related biomarkers, iodine status, and also iron supplementation during pregnancy. So these are the, just by way of overview, the areas that we submitted recommendations in. And I'll go into a little bit of detail on each of these areas. Next slide, please. First, fortification. So food fortification is one of the more cost-effective nutrition interventions. And as shown here, 147 countries have sought fortification programs. A little less than that, 105 fortify wheat flour and 43 fortify edible oil. And this number is increasing as more countries take up legislation, either voluntary or mandatory, to expand fortification where there is a potential to benefit and where it makes sense. But despite this reach, we lack consistent data on program coverage and effectiveness. And currently, the DHS only tracks fortified salt coverage. So our proposal is to expand this to include other commonly fortified foods. Next slide. And what we've proposed is a 3-level measurement framework. So first, coverage, which households consume the food vehicle. And second, fortifiable coverage. Is the food industrially processed, and therefore is there potential for it to be fortified, since fortification requires industrial processing for the nutrients to be added at that level? And third, fortified coverage. Does it contain the required fortificants when it reaches the people who consume? And notably, this third level requires sample collection and analysis. And this is already in place for testing iodine in salt. And iodine already has a field-friendly test kit. So just to be upfront about the logistical requirements of this recommendation, the third level would require that additional step. But the framework will provide program managers and policymakers data that they need for effective decision making. Specifically, expansion of this set of indicators is crucial for understanding the true reach of fortification programs and identifying gaps in the potential for further improvements and other gaps in the levels of coverage that I spoke about. Next slide, please. The second one is food security. And what we're proposing is moving the household food insecurity experience scale from an optional module to the core household questionnaire. Because the FIES provides a standardized way to measure food insecurity experiences. So we're recommending this move to maximize the potential for this data. The HFIES provides 2 crucial indicators. First, the prevalence of moderate or severe food insecurity and the prevalence of severe food insecurity alone. And these measurements give us a nuanced understanding of food security challenges across different populations. So by moving these measurements in the core questionnaire, we would ensure that every DHS survey contributes to global food security monitoring, which would provide an opportunity for comparable data across countries and time periods. In DHS 8, it's notable that only 6 countries included this module. So moving the HFIES to the core questionnaire will significantly strengthen our understanding of global food security challenges and opportunities and support more effective policy responses. And these indicators also complement existing DHS measurement of nutritional status in children and adults. So when combined, they will provide a more comprehensive picture of both food access and nutrition outcomes, enabling us to make or recommend or advocate for better targeted interventions. Next slide, please. The third set is anemia and related biomarkers. So starting with the right part of the slide. So a comprehensive approach to anemia assessment goes beyond just hemoglobin testing. And taking that into account, what we're proposing is measuring iron status through ferritin, tracking inflammation using CRP and AGP markers of inflammation, and in endemic areas, including malaria testing. This provides a more multifaceted approach than just hemoglobin to track anemia. That will help us understand not just the presence of anemia, but its underlying causes. And this information will be crucial for designing targeted intervention that will be more responsive to any actions that are undertaken and monitoring their effectiveness. So historically, DHS has assessed hemoglobin through either capillary or venous samples, but recent evidence has shown that estimates based on capillary samples are less reliable and less valid. So the recommendation that we're making in essence is to first use venous samples only for men and for women and children, and second, to collect the additional biomarkers of anemia drivers that I mentioned. Moving on to the next slide. So the basis for this recommendation is that it's I think we've seen successful implementation of these expanded measurements. In Malawi, Rwanda, and Tanzania, the DHS surveys have achieved high response rates for venous blood collection and testing. So this demonstrates feasibility of this approach, but this enhanced data, and I alluded to this previously, will serve two crucial purposes, really. Informing micronutrient program effectiveness and contributing to global anemia reduction efforts, because if we don't understand the various drivers of anemia in specific contexts, then our responses won't be as targeted and responsive to our intervention. And this data also directly supports WHO's global burden estimates and will help evaluate anemia action strategies. Next slide, please. We also, the group also recommended strengthening or enhancing iodine measurements by including urinary iodine concentration. And because iodine data and trends are best interpreted by measuring different indicators, including population level urinary iodine concentration, and then triangulating these data to inform national nutrition policies and iodine programs. So towards this end, we're recommending the addition of this indicator. So what this will entail really is the collection of urine samples among women of reproductive age and quantifying iodine concentration and then determining iodine status according to established cutoffs for insufficiency and adequacy that are shown in the table to the bottom left. Next slide, please. The fifth and last recommendation that we included for enhanced measurement is more detailed measurement of iron supplementation or iron-containing supplements during pregnancy in a couple of ways that I'll walk through. But in summary, what we recommend is updating existing questions for women with births in the last 2 years and adding new questions to be asked to currently pregnant women. So there are already questions in that are asked to women with births in the last 2 years. So we're suggesting tweaking them so that they address key areas, and then adding these questions to currently pregnant women who are not asked the set of questions currently. So in terms of the specific modifications, the changes first differentiate between IFA, MMS, and MNP. If we look at the first current question, number 426 in the left, which currently doesn't distinguish the sources of the iron-containing supplements. And then secondly, track timing of initiation and adherence patterns and this would be in accordance with cognitive testing and validation studies that have strongly suggested an improved approach to DHS-8. Essentially, they've shown that the question as it's currently asked does not produce accurate information or adherence estimates, and efforts have been made to cognitively test and look at validity studies to recommend specific changes to that question. So specifically ask about the number of months consumed, and then ask adherence questions as well to currently pregnant women. Next slide, please. So this table summarizes the recommendation, the proposed recommendations that I've walked through, and additionally highlights the priority recommendations as indicated in blue font. So if we were to focus in because of real estate issues in the questionnaire, these would be the ones that would be a higher priority. But we feel that the recommendations add strength to the current set. We do note, however, that the adherence indicators will not be directly comparable to previous DHS rounds. So in essence, if we're looking at trend data or looking at comparisons in adherence in previous DHS rounds to including DHS 9 moving forward, what it means that we won't be able to directly compare, because we'll be comparing apples to oranges in terms of the operationalization of the adherence indicator. But we do believe that this trade-off favors the modification, hence the recommendation in spite of this constraint. Next slide, please. Well, this is the last slide, really, but we'll conclude by stating that we believe as a consortium that this represents a significant step in nutrition measurement, and we hope that they have your support and endorsement. And credit to membership of the Global Nutrition Measurement Consortium and all of the discussions that have taken place thus far, and acknowledging the contributions of colleagues who have been engaged until the recent stop work orders. Thank you, Rebecca. Back over to you.
Thank you so much, Mdu. We really appreciate it. And I just want to say we're getting some good questions in the Q&A. Some of them relate to the logistics of some of these. And that's actually the panelists that we're bringing on have some experience implementing a number of these new recommendations. So we're going to bring some of those questions back. There's also a few questions that I'll just be transparent, relate to some of the recommendations that were developed by USG colleagues before they went offline. So we will share and make those questions visible, although we might not have somebody who is well positioned to answer. So just we will make those questions visible because there's some great ones coming. All right, I want to welcome Christine to make her presentation.
Hi, everyone. Thank you so much for the invitation to present today. So I'm presenting on behalf of the SQLNS Task Force, and the task force includes representative organizations, including UNICEF, the World Food Program, USAID, Helen Keller International, World Bank, Children's Investment Fund Foundation, Eleanor Crook Foundation, the Bill and Melinda Gates Foundation, as well as UC Davis. And then we have also individual members who are in organizations who provide SQLNS through their programs. So I just have one slide today because I would like to keep it brief to describe, we just have one proposed modification to the survey. And so if you aren't familiar with SQLNS, it's illustrated down at the bottom of the slide, or actually at the side of the slide, as a small 20-gram sachet. And there are different formulations, but the most common type is a blend of peanut paste, milk powder, soybean oil fortified with vitamins and minerals. And it's provided in daily rations for 6 to 23-month-old children. And some countries, such as Madagascar, Nigeria, and Ethiopia, have begun to integrate small quantity lipid-based nutrient supplements into their programs, and there is interest in further scaling up. But it's a relatively newer intervention in the sort of portfolio of nutrition interventions. SQLNS is a form of home fortification similar to multiple micronutrient powders. And so that was part of the rationale for why we were looking at this particular question in the DHS survey. So on this slide, I'm showing the existing question number 604 that's in the Child Health and Nutrition section of the Women's Questionnaire. And you can see the question asks about in the last 12 months, was the child given any of the following, including iron tablets or syrups or multiple micronutrient powders. So we're proposing adding a third option, option C for SQLNS. And then for both the MNP item and the SQLNS item, the survey managers should insert whatever the local name is used for the product, and enumerators should be asked to show an example of the product, either by carrying sample sachets or showing a photo of the version of the product that's available in the country. So an advantage of adding SQLNS in this question is that by including it the item here together with MNP and iron syrups, we can also roll it into an indicator on the coverage of iron-containing supplements for young children. In addition, we feel that revising an existing question by adding a new response option may be easier and simpler and add very little participant burden as compared to proposing a new question that's just for SQLNS specifically. This modification also would not affect any longer-term tracking of multiple micronutrient powder or other iron intervention coverage. However, we do acknowledge there are some limitations by doing this. The existing question is for 6 to 59-month-old children, whereas SQLNS is recommended for 6 to 23-month-old children. So we are also considering whether we would propose that the indicator be stratified by age. And then we also acknowledge just an inherent limitation of this question with a 1-year recall period that may not be ideal. However, we're hesitant to change the base question in this case in case there have been groups that have been using these data for longer term tracking. However, so despite the limitations, though, we recommend making the revision as a simple method for tracking SQLNS coverage through the DHS surveys. But for countries where SQLNS programs are ongoing, we would recommend that the country consider more specific indicators for M&E if resources are available. So over for me. Thanks.
Great. Thank you, Christine. And I'm going to invite Joyce to present some recommendations on behalf of a team from Nigeria. Welcome, Joyce.
All right. Thank you, Christine. So I'm representing on behalf of Global Alliance for Improved Nutrition in Nigeria, working closely with the Federal Ministry of Agriculture and Food Security and also the Federal Ministry of Budget and Economic Planning. For us, I mean, we are very strongly of the opinion that measuring diet quality is essential for tackling non-communicable diseases, and because it provides critical insights into nutritional gaps, consumption patterns, and also risk factors, especially in the light of increase in non-communicable diseases in low and middle-income countries like Nigeria. So our very first proposal is recommending the adoption of the diet quality questionnaire for key populations. The diet quality questionnaire is a tool that's currently being used by the Gallup World Poll and has been adopted for over 100 country contexts and pretty much takes about 5 minutes to administer the 2931 questions that are in each of the questionnaires. And from this, we're able to produce multiple indicators of diet quality, including the MDDW and adherence to food-based dietary guidelines and NCD's prevention. Most importantly, because it will not increase the time frequency for the survey, putting it side by side the current MDDW model, which asks about 24 to 28 questions. So the current module provides information about only one aspect of diet quality, which is probable micronutrient adequacy. But with the DQQ, it allows for calculation of both the MDDW and other diet quality indicators that are also related to NCD's prevention, making it a major value add to the DHS. Hence, our recommendation to replace the current minimum dietary diversity score for women in the questionnaire with the DQQ. Moving on, also, diet quality data is presently only collected for women. And in accordance with the SDG's primary commitments to leave no one behind, our second recommendation is anchored on this and is proposing to include the DQQ in men's questionnaire as well. Increase the NCD's prevalence among men burdens our health system, and of course it reduces household disposable income, you know, ultimately negatively impacting the well-being of women and children as well. So we strongly do believe that collecting the DQQ data for men would encourage an increased focus on their diet and health, especially with their role as head of house for many households in a country like Nigeria. Yeah. Second slide. Okay, thanks. Yeah. Good. So next, it's proposing for NCD's biomarkers as a model for monitoring cardiovascular diseases and diabetes risk. Currently, the DHS has experience with measurement. In the 2015 DHS report, efforts to measure NCDs in 25 countries between 1990 and 2023 was reported, and the conclusion was that measuring NCDs was a niche model that was more relevant to low and middle income countries. And recently, there's been a collection of blood pressure and blood glucose in the course of the surveys carried out in Bangladesh, India, Lesotho, Nepal, South Africa, and Tanzania. And in measuring blood pressure, this typically carried out using a fully automatic digital blood pressure monitor, and the fasting blood glucose would typically be measured using the HomoQ 201 Plus BG analyzer. And in case you're wondering why we need to keep an eye on NCDs, 73% of all NCD deaths in low and middle income countries like Nigeria occur in low and middle income countries like Nigeria. And with cardiovascular disease and diabetes, contributing a very large portion of these deaths. And this is, this stems from the prevalence of elevated blood pressure levels, which range from 14 to 34%, and blood glucose ranging from 4 to 32% among adults. So you will agree with me that early detection of NCDs and the associated risk is a key component for comprehensive efforts towards reducing the burden being placed by these diseases. Addressing NCDs, has been hampered by limited data due to non-measurement, and a number of low and middle income countries like Nigeria do not have adequate screening and detection programs in place because of limited capacity. Survey data would be an important opportunity to fill this gap, hence our recommendation for an additional and optional NCD biomarkers model to collect both blood pressure and blood glucose measurements in men and women. We do strongly believe that assessing dietary intake and food system trends would help in ensuring that targeted interventions are designed to promote healthier food choices, drive policies as well, and enhance nutrition outcomes. And no doubt a robust approach to measuring diet quality would ensure that all efforts towards combating NCDs are sustainable and effective as well. Yeah, thank you.
Thank you so much, Joyce. All right. So we're getting a lot of good questions. I think there's some very specific questions that our panelists do have some experience with. So we're going to do our best to propose a few questions to them to start off, but then to bring in some of your other questions. And then I do promise that we will take note of the questions that have been submitted, and also make sure that people are aware that these are the issues that people are raising. So I want to welcome our panelists. We're actually going to have 4 panelists. I apologize that we don't have a picture of Dr. Germana Lema, but from the Tanzania Food and Nutrition Center, who will also be joined by her colleague Tedson Lukindo. And they have some experience. I'm sorry, Germana should be over with Tedson as TFNC. Oh, sorry, could you please put that back up so I can finish the introductions? We also have Ana Cecilia Fernandez, who is from the Institute of Public Health in Mexico, who will be speaking a bit about the experience of trying to monitor IFA and MMS in their country. And then we will welcome Etienne Kayigi, who will speak a bit about their experience in Rwanda, looking at anemia and related biomarkers. But then we're going to welcome all of the panelists to share a bit more, especially as we consider some of the questions you've asked. All right, so I want to welcome the panelists to please turn on your cameras, and we will get started. All right. Welcome. So I'd like to start off with a question for each of you, which is an easy one, but just can someone say something about, how important is DHS data to your country when it comes to nutrition information?
Thank you so much. I'll start with an answer from Tanzania, and I think in general DHS is really important for the health sector and even more important for nutrition. It's one of the primary sources of nationally representative indicators on nutrition, and it's very much used in terms of setting up baseline indicators, but as well as for progress, monitoring of progress in the nationally implemented nutrition program. So it's very important, very relevant, and we are quite happy that we're expanding some of the dimensions so that we can get more information out of it. Over to you.
Thanks. Anyone else? Anna, I think you might have a slightly different experience with the DHS in terms of nutrition in your country. Do you want to share?
Well, yes, in Mexico, we have official data currently is the National Health and Nutrition Survey. So that's what we've been using right now. However, I after seeing the previous presentations, I do believe DHS data would be very useful to the country. I'll explain because the information we are picking up, it's only on coverage. So I think these new additions and maybe other possibilities would be very useful, particularly at this moment, at this political moment. Mm-hmm.
We've got a lot of questions, Kune, about the actual feasibility, because some of these recommendations, I think people are saying, that sounds like it could be quite complicated. But I know that some people have experience. So first I want to start with Tanzania. I know you have the experience that food fortification is a really high priority, and that you have actually had the experience of collecting the indicators that IMDU shared. So can you share a little bit about that? Which indicators did you collect? And can you tell us a little bit about your experience, especially collecting food samples, which I think sounds complicated to many people?
Okay, thank you very much. In Tanzania, we have a fortification program which involves salt, iodine, wheat flour, and maize flour, and edible oil. So we collected the indicator of those for vehicles that involves consumption and coverage, or also consumption and coverage of those fortified foods.
And how was the experience of actually collecting in countries and then being able to analyze that data, the food samples?
Yes, we had a very nice experience with this panel. First of all, DHS is a household survey. So that is the very best platform to include household collection of food samples. So we think this is the best approach. Also, the approach is simple and cost-effective because it uses similar protocol and uses similar resources from the main TDHS survey. So we think if we do it as food fortification surveys alone, as a standalone survey, would be very much expensive. And we tried to do the cost analysis, and we found even the field cost is reduced by half if we include in a main at DHS survey. But also we have the problem of logistics, maybe the sample management, but the food sample doesn't require that complex cold chain management as the biological samples. So we find it to be easy to collect and ship between the in the field. But also there is issues of laboratory screening. We find it to be simple because the country can just try to screen it. Initial screening can be done within the country using the qualitative tests, but those quantitative tests, which require more sophisticated instruments, can be done outside the country. But we have also other approaches that can reduce the cost even much further if we include the option of composite sample analysis. So those approaches can be incorporated in a DHS and reduce the cost. Thank you.
Great, thank you. So I think you make an important point, right? Is that it does add to the burden of the DHS, but you're comparing it to trying to mobilize a standalone survey. And for you, that advantage of that extra effort is able to build upon the DHS infrastructure. I hear that. So I want to move over to the measuring of iron-containing supplements. And this is something that I know many countries rely on data from the DHS to understand the coverage of who's being reached with prenatal iron supplementation during pregnancy. And I want to ask you, Ana, I know that your country is in the process of Mexico, of one of the many countries that's trying to shift over to MMS. I'd like to know about, is your current data source that you're using to understand the coverage of IFA meeting your needs? And what do you think about the recommendation, especially this idea that we're going to ask about months instead of the number of days? Because I think that makes some people nervous. So would love to hear your perspective on that.
Okay, thank you, Rebecca. Well, okay, let me tell you the story. In the past, back until 2018, the health sector, through the National Commission of Social Protection, was the one in charge, responsible to monitor the provision of nutritional supplements to women in the maternal health program. And basically, they collected a coverage indicator for supplements for pregnant women and lactating women up to 1 year after delivery. This was done in the context of a conditional cash transfer program that was implemented for 20 years. This program used to provide fortified food, a beverage for pregnant and lactating women, and also a fortified food, a porridge for children, okay? So this data source was not sufficient to change the actual supplements given, the food fortified food given to these population groups. So there were several studies done, specific studies on the consumption and impact of supplements on different nutrition-related outcomes, including, for example, hemoglobin as to measure adherence. Another pilot study at a national scale-up, and also an acceptability study. 2014 was done to change these fortified foods to tablets. So what I'm trying to say is that we needed additional information and not only coverage information to change this supplement back at that time. Currently, one of the ways to monitor IFA supplements is through, as I said before, through the National Health and Nutrition Survey. This survey collects data on the use of supplements during pregnancy. The actual question that was used, for example, in this survey back in 2023 was, during your pregnancy or postpartum, did any health professional give you any supplements? This could be, they had three choices of answers. One was tablets of iron alone. The second one was tablets of iron and other vitamins. And the third one was tablets of folic acid. So These data sources does provide valuable information on iron and folate supplementation. However, the sources need to be updated and expanded to meet the information needs related to the transition to MMS in pregnant women. To effectively monitor this transition, currently data collection systems will need to be adapted and expanded, for example, by including specific questions on MMS use on the national surveys, and by adapting registration systems in health facilities that provide and receive supplements for this population, because otherwise current data sources may not be accurately captured or will not accurately capture coverage or adherence to the new MMS strategy, which is actually being designed, and the first evaluations are now available for this transition.
Great. So it sounds like you do have a need to update and change and have at a national level monitoring of MMS and IFA, so you can actually monitor the transition between the two. And I think some people have some questions, and I actually saw a question in the Q&A about how is it that we could actually go from calculating adherence if we're going to change from asking women about the number of days they consumed. That's what we've been doing historically, but we know that doesn't produce accurate data. So now we're going to we're suggesting that they ask about the number of months that it's consumed. And what do you see as the trade-offs between historical trends, using exactly the same indicator over time, versus switching to a new indicator that's slightly different, given that we're concerned about the accuracy? Do you have any thoughts about that?
Yes. Well, if previous data were collected in days and would be now collected in months, it would be more difficult to compare trends over time without an appropriate conversion. Some women may round up or down the number of months, which may affect the accuracy of the data and lead to an erroneous perception of coverage, right? So if possible, the question would be supplemented with a range of days within the month to refine the estimates. For example, did you take the supplement for the whole month or just some days? To make a comparison.
Yeah, and I think that's actually right now the proposal is that you ask about the number of months, and just like you're saying, then to say, what was your usual intake in a week, to try to get this sense of whether or not there's adherence. But we do acknowledge that this will add a complexity. Although the challenge is, if right now the data we're not getting is not accurate at all, do we want to continue collecting data that way? So I think it will require transition, like you said, and I think that this recommendation does include, like you say, trying to get a sense within usual intake. So great.
But we
believe it's possible. Good, yeah.
Yes.
Transitions are hard. I do want to bring up, so biomarkers are another question. And I think our colleague, Etienne, I know your camera is not working, but could you just turn on so we can we hear you? You mind?
Yeah, good afternoon, everyone.
Good afternoon, welcome. So we understand that Rwanda—
Sorry, I failed to turn up my camera.
That's okay. We can hear your voice clearly.
I can intervene without showing my face.
Great. Well, we would love to hear a little bit about your experience implementing a micronutrient module as part of the DHS, because we have proposed collecting a number of biomarkers related to anemia. And so can you tell us a bit about your experience, how that has been, and how useful the information is coming from the DHS?
Yes. Are you seeing my screen?
We do see your screen.
Yeah. Yeah. Good afternoon, everyone. I'm happy to join this platform and share Rwanda experience on the RDHS 6. We conducted since September 2019. So in this Rwanda Demographic Health Survey 6, we had 2-in-1 projects. One part was the usual markers, malaria, HIV, and other indicators used to be collected in the previous years, I think 2003. So the second project was micronutrient project, which was a new project introduced in 2019. So I was at country level, I was coordinating this activity and I had a team in charge of collecting samples, processing samples, temporary storage of samples at health center or at a hospital near the collection site. And every Friday, we had 2 cars which was in charge to bring back those samples from the sample collection site and temporary storage site and those samples were shipped to the National Reference Laboratory Division, which is one of the divisions making up Rwanda Biomedical Center. So in few words, this is a type of samples we collected. In total, we collected 28,104 samples. And all of these samples were tested. The report, maybe the comments on the right side is not, it has not, it is not, it needs to be updated. Don't consider, but this is actually the type of samples we collected. 3 or 4 types of samples. One was urine samples. Second one was salt samples. The urine samples were collected from a woman which was pregnant or who has breastfeeding kids below to 5 years. So the salt samples were collected at community level and also in the market. The serum samples and the last 2 were blood. One were a blood collected in a sample without anticoagulant. The second sample was collected in ADTA tubes. This, in few words, this is samples we collected. Some of these samples were tested in Rwanda at a National Reference Lab and also at Rwanda Standard Board, especially the salt samples. For blood, all the bloods were shipped in different countries for testing purposes. So the DHS micronutrient report were published, if I remember well. I think it was in July last year.
Great. Thank you so much, Adian. I appreciate giving us this detail about, I think, really appreciating that it is feasible, but it also seems that logistics in turning where analyses can be done and how they can be done are complex but doable. I think there was a good question. I just want to pick one up. There's so many good questions in the chat. A couple of people have asked about urinary iodine, and it looks like that is something that was done in Rwanda. So I want to encourage people to reach out perhaps to the Rwanda team. Also, was urinary iodine done in Tanzania? The TFNC team, was that an experience you had?
Actually, our team was trained in Tanzania. Then they came back to Rwanda and tested the RDHS 6 samples.
Okay, so Tanzania is the source. So we are going to encourage people to reach out and learn from the Tanzania experience. But I would like to hear, someone raised this question of, so if we do this, do we no longer need to do standalone micronutrient surveys? And I would love to hear the perspective of
Sorry, come again. I didn't get clearly your question.
Okay, so I would like to ask, so I'll have the Tanzania team answer. So do you feel like if we do this with the DHS, is there still a need for standalone micronutrient surveys?
My quick question
The last
would
one I
be,
didn't pick well. The last word, and I think it is the most critical one. If we do conduct, currently we are planning to conduct RDHS 9, and micronutrient will be part. But not all of those markers I have presented to you. Currently, I think we look at, based on the outcomes of the RDHS 6, currently we are going to focus only on anemia.
Great. Thank you so much, Etienne. And I'll just give the Tanzania team a last word about whether you think this is sufficient for your micronutrient data needs, or do you still see there's a need for standalone micronutrient surveys?
I think my colleague Tedson alluded to this. So if we are to do a standalone micronutrient module, it will cost us twice the amount of resources that we really need to do the DHS. So I think combining the two, one provides more efficiency in terms of design, data collection, and cost, but it also provides an opportunity to triangulate information, particularly if there are other modules such as intake, MMS, and the like. And I think it's an opportunity that most should try and use. Otherwise, you'll have difficulty to really understand what is driving the change that you are seeing in the biomarker indicators. Over to you.
Great, thank you. And I want to apologize. We have lots of extra questions, and I'm going to tell people a way that maybe some of those questions can be answered, but we've noticed. So thank you to all the panelists. Really appreciate your participation. And I'm going to ask that you put this last bit of slides because I want to make sure everyone knows the way that you can actually learn more about these recommendations and potentially even submit some of your own. So again, we are not fully certain about what is happening with the DHS program, but the DHS questionnaire revision portal remains open, and we'll put the link to that portal in the chat. And so you can actually get on and review and comment on the recommendations that you have heard about or submit a new recommendation. And I'm just going to walk through because I want to make sure everyone feels like they can do this. So when you get onto that portal, what you're going to do is you're going to go and you'll see a button that says Review Feedback. And when you click that button, they're going to ask you for a second step to validate your email. So you actually have to submit your email. They will send you an email to your email. You click on that link, and then you come back to the portal. Once you're there, you're going to see a long list of topical areas. And you actually have to scroll down to see all of these areas. But the nutrition recommendations, the ones you've heard about today, will be in 3 of these folders: the nutrition folder, the biomarkers and anthropometry folder, and the current module household food insecurity experience scale. And there also are other recommendations in other areas of the DHS that you can see as well. Now, if you click on these, you'll be able to actually select the particular recommendations. And so you can click on one of these recommendations, and then you can read through it. And at the very end of that reading, you'll see on the right, there's actually a button to like or to post a comment. So for some of you who've been raising some questions about what is the feasibility, what we encourage you to do is actually to go and read through the full recommendation, because I think some of the questions that people have raised are addressed in these fully posted recommendations. But for other of you, you might have a remaining question. But the number one thing is the DHS program takes into account the comments and the promotion of the wider community. So if you are interested in these recommendations being taken up, it's really important that you log on, that you look, and that you comment or you like and you show your endorsement for these recommendations, because that is really our most effective tool right now to communicate to the DHS program about what is needed. Now, you might not agree with every single part of a recommendation, and that's where that comment, you should feel free to add your comments. I can say that all of the recommendations that Imdu shared about have been posted, and I believe that the other recommendations that Christine and Joyce shared about should be posted in the coming days, and we will try to flag through Data for Nutrition when those get posted. So again, an hour is too short given this rich topic, but we really do hope that this has been a helpful presentation, made you aware of what some other people are thinking about how to improve the DHS surveys. Remember, you can get on and also submit your own recommendations and ideas. So we really wanted to encourage this community as a nutrition community to come together and submit. All right. I just want to thank everyone. We've hit the top of the hour. Want to say thank you to all of you for participating. I really want to say a special thank you to our speakers and our panelists. And just to say that we as a community are going to continue working together on this issue of nutrition. So thank you so much for joining this webinar. Please go to the YouTube channel if you'd like to share it with everyone. And we look forward to the future. Thank you, everyone.
Thank you too. Thank you, Rebecca and team.
Thank you all.